Welcome to the Transforming Trauma podcast. Transforming Trauma is presented by the Complex Trauma Training Center. I'm your host, Emily Ruth, and I'm so glad you've joined us today. Licensed mental health professionals, we warmly invite you to join our Spring 2026 NARM Therapist Training, a live online immersion into the transformative power of the neuroaffective relational model. This advanced clinical training is designed specifically for those seeking to deepen their expertise in healing complex trauma while offering the accessibility of an online format. From January to August 2026, you'll be part of a supportive virtual community of learners integrating mindfulness and clinical expertise. Through 4 comprehensive modules, you'll gain specialized trauma-informed knowledge and skills to confidently and compassionately address the impacts of adverse childhood experiences and complex trauma. Together, we'll explore how to support the resolution of attachment, developmental, relational, cultural, and intergenerational trauma using a neurobiologically informed approach that promotes post-traumatic growth. Embodying professional and personal growth, you'll become a catalyst for transformation in your practice and community. Enrollment is now open for licensed psychotherapists, counselors, social workers, psychologists, and other mental health professionals, as well as graduate trainees and interns working toward licensure. Visit complextraumatrainingcenter.com to learn more and secure your spot in this online training opportunity. And now for our interview. Dr. David Puder is a psychiatrist, educator, and host of the Psychiatry and Psychotherapy podcast. He completed his psychiatry training at Loma Linda School of Medicine, where he later joined the faculty and earned a certificate in adult psychoanalytic psychotherapy from the New Center for Psychoanalysis. He's the creator of the Emotion Connection Training Program and founder of a nonprofit focused on advancing mental health education. Dr. Puder now runs a private outpatient practice in Florida where he takes a holistic approach, integrating psychotherapy, medication, diet, exercise, and lifestyle. His work has been featured on NPR and ABC7. Please enjoy this conversation with Dr. David Puder. All right, I'm sitting here with Dr. David Puder. Welcome to Transforming Trauma.
Thank you. Yeah, it's good to be here.
So happy to have you. And we always start with the question that I think is a good one to begin with, and that is, what would you like our listeners to get out of our time together today?
You know, I think encouragement for the work that we do. I think that a lot of the work is very when we're doing it well, it's exhausting. And so if I could leave the listeners with some equipping, some enlightening, some, feelings of the work that we do is meaningful. The work that we do is sometimes difficult, but it's the best work to do. And I'm excited to come on and talk about trauma and talk about therapy, talk about psychiatry, psychosomatic illness, psychogenic seizures, dissociation, and so thanks for having me.
Awesome. So great to have you here. If we could kind of rewind a little bit and actually go back, just in case our listeners aren't familiar with your work, could you sort of give us a snapshot into how you got into this work? What brought you here?
Yeah, I was not someone who was thinking about becoming a psychiatrist, becoming a therapist in high school or even medical school. It was really towards the end of medical school that I felt like maybe I should give this a second shot. So I did a transitional year, and then I spent some more time on a psychiatric ward, and I decided to go into it. And it was really my first year as a psychiatry resident that I met a great mentor, Dr. John Tarr. He was a psychoanalyst. He was at the time 80. He had been doing therapy for longer, maybe double my life, right, at that point. And he was just such a warm, loving human being. And I remember listening to him and being like, what is he talking about? It's like just on the edge of my seat trying to grasp the depths of human connection and decreasing shame, attuning. He was incredibly naturally empathic, maybe too much so. Maybe I say too much so as in like, I think it wore on him sometimes how empathic he was. And so it kind of developed into a lifelong mentorship. And so after residency, I stuck around, co-taught with him, went to a psychoanalytic institute in Santa Monica, the New Center for Psychoanalysis, and stayed on as faculty at Loma Linda. I split my time between doing psychotherapy. I ran a program for medical and psychiatric issues, so people with like the psychogenic seizures, chronic body pain, really a lot of complex trauma, disease identity, where they started seeing themselves as a disease. So, they introduced themselves as, I am diabetes, rather than like, I am someone who suffers from diabetes, or I am a person who's creative and loving. I'm a mother and I suffer from this thing, but that's not my identity. So we tried to shift their identities. We tried to get them to process congruently in modalities that they were capable of processing in, whether it was writing, art, or talking. And if they were congruent in one space but not the other, we would start them there and then have them describe the art congruently, describe the writing congruently. So did that for a while. And then during COVID, we moved to Florida, mostly for my kids and to be around some family. And in Florida, I launched my own private practice. And so I have a couple providers and I do psychotherapy. And just October, just this last October, I took a step back from the IOP partial. I was running it from Florida. And so in the midst of that, I guess, I started the podcast Psychiatry and Psychotherapy, which is kind of an eclectic blend of good medication management, for severe mental illness, things like schizophrenia, bipolar. We talk about medications that there's no drug rep coming to your office to describe. Lithium, is still, I think, a great med for true bipolar. And I say true there because I think a lot of people are overly diagnosed with bipolar, especially in the 80s. And, we talk about things like how people with borderline personality disorder don't necessarily benefit from medications. We talk a lot about exercise, diet, and psychotherapy. So I've had on the similar people that you've had on. I was just listening to your Shedler interview this morning, and Nancy McWilliams, and I just had Odo Kernberg, who, is just a wealth of wisdom at the age of 97. And so that's a little bit about my history.
Yeah. If you haven't been to his podcast, it's such a rich exploration. You just named off some good things that you chat about over there. So check that out if you haven't already. Well, thank you for that. There's something you said that kind of jumped out at me, and I wonder if we could kind of go down a little bit of a side trip, maybe.
Let's
that okay?
do it. Yeah.
Well, you talked about what I'm thinking of as disidentification. You said when you help them shift their identities. Can you talk a little bit about that process?
Yeah. So, people who are suffering, they go into the medical sphere, and they're not often even referred to therapists for decades. So they're treated as medical patients, and they get their connection needs met through, medical issues, taking medication, having, good connectedness with physicians. I mean, well-meaning physicians. And I've worked closely with those physicians, like neurologists who walk with patients for years with seizure disorder, trying to figure out what's going on. The average time till diagnosis of psychogenic seizures is 6 years. So a lot of those patients, for 6 years, they've been in the medical system taking mood stabilizers for what they consider as, seizures with epileptiform activity in the brain. And then eventually they get the diagnosis of that there's no epileptiform activity originating the seizures. So these are more dissociative seizures. These are seizures caused by a lot of psychological distress, often complex trauma, often, things like sexual abuse. And so they end up in the medical system with a medical diagnosis, getting their connection needs met, often in a mediocre way from doctors. And they never really get to the root of what's really driving all of their distress. And so, the well-meaning doctors help them form an identity that is not based on the beautiful things about them, right? The creativity, the curiosity, the things that are going well. It's based off of illness. And so when they come into therapy or come into the program, we try to not give the illness as much attention and look at the strengths. I try to specifically, I would look at the emotion that is tied to the events that they come in with. They have a lot of emotion around their experience of being in a medical system that is often not very empathic. And so I would get them to talk about that, and I would attune to the at times they would feel a lot of shame, a lot of frustration towards certain treatments, and just feeling stuck, right? And so I would attune to the emotion, and then I would look for the strengths. Like I had one patient who had 10 very fringe diagnostic categories, but this person was very gifted in a certain area. I'm trying to be vague just because of HIPAA and protecting their identity, of course. But so I would really focus in on this. And they came in with here's a 10-page list of all the medications I've tried and all the side effects I've had. Because this is how this person connected with intelligent doctors who she would tie their mind into knots trying to figure out what was going on with her. And so it's kind of a counterintuitive thing to do, to not give that as much attention. And I can understand all that stuff and understand what she's on, but inevitably medication, if it was going to be the solution, would have been the solution after 10 years of trial and error. So instead, we tried to convert these very medicalized patients to more of a psychotherapy patient, to seeing that they could get their needs met first in the psychotherapy experience, but then in their family experience. So we did a lot of family therapy, invite the families in, try to get the families to connect with them congruently, which often wasn't the case. So often what would happen is if we just did individual therapy, they would go back to their family systems. The family would, for whatever reason, the family sometimes would be in an equilibrium where it would be beneficial for them to be ill, the stated ill patient, ill family member. And so by helping the family not connect in illness anymore was also part of the process of getting them out of this cycle of being stuck in illness.
Yeah. Wow. We could probably spend hours and hours talking about that. And that stuff is fascinating to me. I'm really interested in family systems. And so you're really speaking my language here as you're naming this piece of like, folks can identify with kind of the illness side, but also those around them can also kind of identify them as that thing, whatever they're struggling with. So that's really important work. So I appreciate you going down that road with me a little bit. So you've named complex trauma, and that's obviously something that you're dealing with pretty consistently. Can you talk a little bit more about how you hold that? Like, what does that mean to you, complex trauma?
Yeah, I actually did a deep dive on this, looking at factor analysis, looking at different studies that have looked at this. And I know that some people don't like that word. I know you guys do, so I'm in good company here.
Yep.
Essentially, there's this idea that there's a cluster of symptoms that don't really fit into borderline personality disorder, but they have a lot of trauma. And so the ACE scores are very high. And it's like the odds ratio of having this issue jumps up 25 times more when they have 5 or 6 ACEs, adverse childhood experiences. And they don't look like the classic borderline personality disorder because they're very avoidant, actually. They don't want treatment. They don't want connection. It's like as if the trauma and the interpersonal hardships have left them to want to withdraw, not to sort of pursue relationships. They don't get angry and volatile. So they're, the patients that I often score the big five on people about, where they look at neuroticism, and in the neuroticism subdomain, often their anger scores are actually very low, which if they have narcissism, their anger scores are going to be high. And if they have BPD, usually all of neuroticism is high, and anger is high with everything else. So in people that I would consider in sort of the complex trauma group, you have more of the avoidant and attachment style. You have more of the withdrawal. And this is just coming from the factor analysis stuff. I think it's sometimes more broadly used as like a catch-all, but I see it more as like the withdrawers, interpersonal withdrawers. It's like the interpersonal trauma has been so much that it's so painful to even consider another connectedness with another human being, but they desire connectedness.
Yeah.
So there's a push and pull. And I think for people who are maybe more familiar with personality styles like Jonathan Shedler, it's my impression that everyone has a personality style and it's not a disorder. And so some of the personality styles that might fall into more of the complex PTSD include things like avoidant personality style, schizoid personality style. If you've ever read Kafka, I think he was, and Einstein, depressive personality style, which is more of a high guilt, very self-critical internal voice. So I think within complex PTSD, it's actually useful to consider that there are different types of personalities and ways of coping, mechanisms of coping. Not that these are going to be there for life. Not, I have these as well. I don't think it's like a disorder. I like to take disorder out of it. But I think it's a further way of understanding the depth of someone's situation, is to understand that how they would cope with particular distressing things in an adaptive way. Maybe historically it was adaptive. Sometimes now it's maladaptive. It's not serving them anymore, but it was historically adaptive. And so I don't. Does that give you a framework?
Yes, okay. And I appreciate. I can't remember which interview with Shedler. He gently guided me in this direction of like, let's second guess disorder here. And I've been thinking about that since. So I really appreciate you naming that. And I'm sure for our listeners, this is all, vital territory as well.
Yeah. Yeah. I think the idea of disorder is, it's once again, this idea of like, I can base my identity on disease. There's something wrong with me. And actually, this is my pushback on the AA model as well. Like, what's my identity? I am addict. Right? It's like, no, you are someone who has struggled with addiction. Yeah. You are not an addict. Like, it's like, I would say that's not how we want to base our identity. We want to base our identity off of like the creative aspects of ourselves, the unique qualities, and So in my family, and how we practice this practically is whenever we're at a birthday party, and me and my wife do this. We've been doing this for a decade. If someone's having a birthday, we say, "Hey, let's go around and say something about this person that we appreciate." Mm-hmm. And everyone kind of like haphazardly starts going around, like, I appreciate this, but it's like, that's the identity of this person. Right. Mm-hmm. Like I can already tell Emily, like, I'm like, I could see you as my therapist, like you have like a great ability to mirror. There's no like still face going on. There's, for those of you who are just listening, she's very emotionally attuned, to the moment to moment changes. And so I think, even without knowing you very well, I can see that. I hope you post these on video too, so people can see that.
Thank you. Yes, that is the plan.
Okay.
Yeah, I appreciate you saying that, first of all. And I've had that experience of kind of this, let's go around and like share, how do you see this person? Like, what are these qualities that we're talking about? And I've been in that place a couple of times, and honestly, I will never forget them. Hearing the people that are important to me, like, share how they see me and maybe strengths that they see, it really is impactful. And so I love to hear that you're doing that at birth. What a great idea. Every birthday, let's
We just take over the party. Yeah.
I love
And
it.
no one has ever been, there's been some people who are just like really embarrassed, but then they like secretively
Underneath,
like
I
it.
love it.
Yeah. Yeah.
Oh, that's so great. I love this. And I appreciate that is actually kind of my pushback thing with AA. There's so many beautiful things about the community, and there's a lot of great things about AA. And that is one piece that I can see too, that to really identify with the kind of, pathological side of what someone's experience is, how that's not really useful in a lot of ways. So, yeah.
Yeah, I really like Viktor Frankl here, and I know I heard your quote at the beginning of one of your things.
Mm-hmm.
So it's like Viktor Frankl said, like, we end therapy with the strengths. We don't like overly analyze the strengths. If someone has, in my mind, like a very solid, good spiritual core, it's like we don't necessarily, try to deconstruct their strengths. The things that they naturally gravitate towards. Spiritual being like where we find meaning and purpose in the world, right? And so, like if someone's finding meaning in suffering, I'm not going to point out that they're masochistic, and unless it's hurting them, of course. So yeah.
Yeah. Well, before we pressed record, there were some other really interesting things that I know we could talk about. And so, is it okay if we kind of shift gears into some? What is feeling most present to you in this moment? Like, where do you want to go?
I think talking about dissociation might be interesting.
Mm-hmm.
And I'm sure you guys have talked a lot about this. And
I'd love to talk about it with you.
Okay.
So go ahead, riff. Let's hear it.
Okay. So I think about dissociation as like the lifespan of like the experience of dissociation. So I would go back to like even temperament. And so there was some longitudinal studies where they followed kids and they looked at how they sort of reacted to stimuli, even coming out of the womb. And I think that some kids are just a lot more reactive to stimuli. They take in a lot more. And then, so I think those kids have the potential to be overstimulated. And so I start there. And then Beatrice Beebe, the work at 3 months of age, and then she followed them up, and then she found that there were certain patterns of mother-infant interactions at 3 months that predicted disorganized attachment at 1 year. And a lot of it was the mother and infant misaligning in terms of attunement. So child would want space, child would be pulling away, mother would be looming in to try to like sort of reconnect, right? The child would have a grimace or an unhappy expression, and mother would have this smile. Child would have a smile and mother would have a frown. So it was just a disconnect, even at like 3 months of age. And that predicted disorganized attachment in the Mary Ainsworth attachment interview. So at 1.5 years of age, when they do the attachment interview, what disorganized attachment looks like is that the infant doesn't have a concerted way of reconnecting with the mother. So they leave the mother in the room, mother leaves, mother comes back. If the child has a normal secure attachment, the child comes to the mother, is distressed for about 30 seconds, the mother attunes, child goes back to play because there's a lot of toys in the room. Right. So it's like pretty quick reestablishment of joy and like play. If it's an anxious attachment, that the child will be very distressed, angry, maybe pound on the mother when the mother comes back, but the child goes to the mother, right? The child is distressed, but goes to the mother, shows the mother how unhappy, and it takes them a long time to console, to get back into playfulness. The avoidant attachment, the mother comes into the room or the mother leaves, the mother comes back into the room, and the child is playing, not even maybe looking at mother, but the child's cortisol is elevated. The child is distressed, but the child has learned that the most adaptive strategy is to pretend as if they're not distressed and just pretend as if they're just playing. That's avoidant. Disorganized is the mother comes back in the room and the child may start to move towards mother, but then maybe enter into like just kind of a trance-like state and just stop. Maybe they flop on the ground. So they don't have a concerted, organized way of reconnecting with mother. And so this is disorganized attachment at 1.5 years of age. And then they follow these kids and around 6 years of age. And is this new for you, or is this like
I've heard it, but I'm thinking of it through your lens and where you're taking this. So I've heard it, but this also feels fresh.
Okay. And if you have like a different things to add, I would love to hear your additions to it. They follow these kids, and some look at the age of 6 callous or unemotional. Mm-hmm. And and I wonder if that callous unemotional trait, sometimes they're getting in trouble at the age of 6, 7, 8. Is that really just like they're more dissociative? They're more like they're not in connection with their emotion, and they don't really know how to connect with other people well. And so these are like the high risk kids that, like, if they don't learn how to play well with other kids, they're in trouble. And interestingly, if the parents had a very secure, warm attachment and they were disorganized at 1.5 years of age, they would be pretty normal by 6. And so it's not like a death sentence for a kid if they're disorganized at 1.5. The kids in adolescence, the one thing that's highly predictive is more of a dissociation. And even up to 28, dissociation is the key. And this is beyond, there was one early study that showed that they may have increased rates of BPD, but actually a further study showed maybe not, and maybe it's just dissociation. So I think that the disorganized attachment of infancy, if they're not in a very good environment, this is where the complex trauma picture really can settle in, more of the dissociation. And it's almost as if in that dissociativeness, they can have a harder time connecting, getting their emotional needs met. And so this is more of that developmental trauma that I think you guys are really interested in. And I think your approach actually works for it.
Yeah. So. Again, this is like, you're speaking my language here. I mean, even as you're talking about, what's like shaping this in the beginning, so that these infants that at that young, they're already having these kinds of, they're understanding so deeply how I need to show up in order to be okay, in order for the environment to like settle. Like it's wild how early we do that as humans. And so I appreciate how you're talking about this for our listeners. Can you say a little bit more about your relationship or how you're holding dissociation? Because I think there's a lot of different ways to relate to that, even that term.
So what I have found is that, like, when I worked at the VA, it's like the vets would tell me the story of some narrative of their supposed trauma experience. But often this is the story they had told 20 to 30 times before, and they had left out the piece that was actually the dissociative piece. Okay. And so I think as an astute clinician, you have to look for when they start breaking down, when they're not able to get their words out maybe as well. The part of the story in cognitive processing therapy, they found that this is the part of the story where there's a lot of guilt. I think you guys see more of the shame. And I think that it's like in that part of the story, it's almost as if what I feel when I'm in with them is I start to feel like the haze of almost like a battlefield. uh, it's almost like that feeling. I played, I was a D1 athlete. When you're down and you have to keep fighting, and if you don't keep fighting, you're going to lose. But it's like you feel this energy just decrease. And so often what's happened is people, when they've had experiences like that and they tell anyone else, if the person that they're telling is not trained, it's almost too much for the other person. So I've heard so many stories of kids going to their parents, like, this happened. The parents like either shame them, either get angry, or go flat-faced and don't say anything and never talk about it again.
Mm-hmm.
And so that becomes a secondary trauma almost, because to receive a still face in the face of your own dissociation, it becomes for some people like the big deal, like, why did my mom not attune to me, and why did she shame me and tell me it was all my fault and lay in this guilt, and or why did she just look at me blankly, right? Or why did I go blank in the midst of the trauma, and so the dissociation is kind of like this moment where all of our psychological defenses are no longer working. And so we go blank, we feel lightheaded, we feel disconnected from our body, we feel like we're on the top of the room looking down. We may feel like we can't move. We may feel kind of spacey. And I think that all humans dissociate occasionally. And I think that, some dissociation is actually kind of fun. We can like, I think a lot of smartphone usage, when people are flipping through videos that are like short videos, it kind of is a dissociative phenomenon. And it kind of like jars you back and forth with emotion, where it kind of like gets you into a more dissociative space. People dissociate as they drive home. Sometimes they forget where they drove. But there are people that tend to dissociate easier, and either there are the high neuroticism people on the big five. There are people who have been through a lot of dissociation through trauma. They take in a lot more sensation. So highly sensitive people, I think, are more prone to dissociation. And so what am I doing in the room is sometimes I'm looking for what is the emotion that is disavowed. I'm looking for the anger that's disavowed. And can I get them in touch with maybe even disgust? So this is where the micro-expression work that I've done and the trainings that I do, there are micro-expressions that even in the midst of dissociation and then in the telling of the story, that flash on the face, sometimes anger, sometimes disgust, sometimes pain. So anger is just a quick down and together of your eyebrows. Pain, there's a widening of the mouth and a down and together of the eyebrows. And disgust, there's the upper lip goes up and there's a wrinkling around the nose and the eyebrows go down and together. So there's some subtleties there, but I may use that to kind of try to search if I can get them in touch with that. Now, I'm not like just going to point out like, oh, you feel anger. That could be very shaming just to even point out their emotion. Sometimes I think it's helpful to just, if just to be with them and for it to be okay that they're dissociating. Any way that you can reduce the shame through words is potent. And sometimes I get creative in the midst of dissociation. So it's very intuitive with different patients. So like one patient I would have walk around with me, would go for a short walk and just feel her feet on the ground. One person didn't like that at all. And they like to just look at me and to kind of ground themselves in just the face to face. Another person didn't like to look at me. And for her, talking about cats can be a way of pulling her out of the dissociation. So yeah, I one size doesn't fit all. I've done a lot of I've tried a lot of different things. You go to conferences, you hear about somatic experiencing and like move back and forth, and sometimes that helps, sometimes that doesn't, right? Holding ice, I think that's what DBT uses a lot. For some patients that works. For this other patient, it sent her further into dissociation. for me, a cold plunge can get me out of a dissociative state. If I've been doing trauma work all day with my patients, I'll get in. I have this like sauna, cold plunge, doing that back and forth can just, it's totally my jam. But other times it's like processing the stories with my friends and colleagues, and just receiving kind of like empathy, I think is helpful. Yeah. What about you? What do you feel is what?
Well, as you're talking, there were so many things that came up for me. I mean, if we were to rewind back a little bit, talking about the mom and, like a child coming to a parent and mom doing or dad doing any number of things. They could like get explosive, they could go kind of still face, or they could check out, or they could blame the child. Like there's so many different like potential, reactions. And I'm thinking if mom in that moment, I'm a mom, so I'm putting myself in that place.
Okay. How old are your
kids? Yeah, in that moment, my child comes to me and tells me something. I know I'm like sort of talking myself through like, okay, I don't want to overreact. I also don't want to underreact. Like there's part of me that's like staying connected to like, what does the child need in this moment? And I'm hearing you you didn't explicitly say this, but I wonder if you're getting curious about what is the function of if there's dissociation, like what is the function of whatever's happening in the moment? I don't know, that's where my mind went. I don't know if that's something that you do with clients when they're sharing something. I mean, even just thinking about, and maybe because I saw the picture of your head with the cat, I was like, that's a rad painting. Like thinking of the client who will come out of dissociation talking about cats. Like, I'm just wondering how you're holding that. Like, are you thinking, what is the function in this moment of the dissociation? Or I don't know. Does that make sense?
It's like the why, right?
Yeah.
And it's like why was this adaptive? Why is this adaptive? The nature of dissociation is to not have words to describe, and so to be able to start to describe, I think, is invaluable. To put words to something, it integrates the brain, it integrates the putting words to things, creating a narrative. I think interestingly, so I know in cognitive processing therapy, they did a study where they did cognitive processing therapy versus cognitive processing therapy with written work around the trauma. And only in the patients with dissociation was the written work valuable. And so I looked further into like writing as part of therapy. And I do this with some of my clients who are more dissociative, and it's very valuable. And I'll look at the writing and then we'll try to deepen it, so we do revisions. And so like I had one patient who wrote a letter to her mom, basically telling the mom how she had been hurt. And I was like, look, I think we need to like describe this more viscerally, because like, I think like it's like you're kind of letting your mom off from this. And I don't think like, and so we did, and that increased the potency and the emotion and the sort of processing of the loss and the anger. And so it's sometimes there's a process of revision, I think, where we're looking for the disavowed portions of the story. But yeah, creating a cohesive narrative of the why, I think, is valuable. And I would add that it's actually a part of reflective function. So this is something I would love to introduce to your audience. It's like something I totally, it has shifted my understanding of what makes a great therapist is reflective function. And there was a study that was done where they looked at the therapist reflective function and outcomes. And so I've been very interested in therapist effect and how some therapists are better than other therapists. And we can attribute some of that to therapeutic alliance, some of it to empathy, some of it to handling difficult interpersonal situations. But reflective function, and the study that looked at it, it was 70.5% of the variance in therapist effect was due to therapist reflective function. And so a lot of these other studies that I mentioned before, there's like 0.3 correlation. It's like 0.3 correlation. It's not incredibly seductive. I mean, it's more seductive than modality. I would argue that like, I would pick my therapist based off of the therapist rather than the modality.
Okay.
And I'm okay. So what is reflective function becomes the question, right? And it is as complex as you can imagine, because it's based off of the adult attachment interview. So they actually had these therapists do the adult attachment interview. And there's specific questions in the adult attachment interview, which are like, why do you think your mother did that? Why do you think your dad did that? Why did, and it's the why questions that are, it's a demand question. It's demanding you to reflect upon what is going on. And in that process of your articulation, you can grade reflective function. Okay. So reflective function is actually graded on a 11-point scale from -1 to 9. And so why is there a -1? That's an anti-reflective function stance. It's actually against reflective function. So if you were to be like, why did your mother do that? And a patient would say, I don't know, you. Like, you're the therapist, you tell me.
Mm-hmm.
How dare you ask me why? That's a -1. Okay.
Got it.
A 3, which is actually where most like inpatients with borderline personality disorder live. 2.7 in most studies is where they are. 9 being the highest once again. So 2.7 is where most people with BPD are, and actually eating disorders as well.
Mm-hmm.
So BPD, they might answer in a non-mentalizing, non-reflective function way. Well, she was a narcissist. Okay. Well, okay. Like, tell me more. Why do you say that? Well, she just was, or she was a, so it's like not, it's like kind of like a cliche almost in the way that they answer it. And, so here's a high reflective function stance. Okay. So a higher reflective function, like a 6, would be something like this. When I was a kid, I thought my mother was like that because she was so angry at me that she lashed out and she just hated me. But now as an adult, I realize there's a complexity to this. My mother was working 2 jobs, and when she would come home, she had very left in reserves. And then on top of that, my mother's mother was very abusive. And so this is all my mother knew on how to behave towards me, was to just repeat the pattern. And not to make an excuse for my mother. And I think that she got better as she went on in her years and she was less abusive towards me. But I think initially she was just completely exhausted and it's very unfortunate that she did this, but I feel like perhaps with hindsight now, I realize just how she was suffering and she took out her suffering on me. So you can see like there's like a story. There's like, this is how I felt back then. This is how I feel now. This is how her parents influenced her. And all of this comes together in an authentic and real way that's not a cliche. That's not something that's just a pop psychology understanding of it. Okay. And so when the therapist could do this, and I don't know if I did this really that well as well. I mean, you could kind of piece together like, well, is she overly like seeing her mom's perspective and not her own? So maybe a more reflective way would be, like, of course, now I would never do this towards my own kids, and I've like worked through this to where I can be the mother I want to be. I don't know. So maybe there would be some depth there. But anyways, my point is that if a therapist could be articulate towards their own story and this would allow them to help their patients do likewise. Okay. And further
capacity to hold the complexity, all the nuance and all the, okay.
to hold the complexity. Yeah. And so I've sent some patients to get their AAI done. And sometimes they're high in some parts of the story, but low in other parts of the story.
Oh, interesting.
And so I actually think a good example of this might be Freud. Freud, I think, had low RF in regards to his relationship with his mother. I think he overly idealized her and went all good on her in some ways. So in the Rat Man, he believed that the Rat Man, which like awful to call your patient Rat Man, he believed that this guy was mostly had issues with his father. But in the Rat Man, he wrote his own memoir of his experience with Freud. And it shows the negation of the complexity of his relationship with his mother and how Freud negated that complexity. And so you could see how, like, if you as a therapist had sort of unprocessed parts of your past, how you might project that onto a patient. So if you have unresolved conflict with males, you may see the males in your patient's life as more narcissistic or more conflictual or more, like if you have, I had this one therapist, oh, you're going to love this story. So patient newlywed came to me first session, just trying to get to know her. She had developed pelvic pain soon after getting married, virgin until the wedding, first sexual encounter, not bad. After the honeymoon came back and all of a sudden during sex started developing pain. Went to a therapist, first therapy session. The therapist had told her that she probably had some unresolved sexual trauma. In the second session, I was more curious about this. I was like, well, tell me how is the therapist asking these questions? Then she's like, well, the therapist says things like, did your dad ever take a bath with you? Did your dad, while he was in the bath, look at you in certain ways? And then the therapist had disclosed to my client that she herself was sexually abused and had pelvic pain after sex, right? Okay. So sometimes that can happen. Sometimes people can have pelvic pain from sexual trauma. However, on further history, during the second session, I realized she had had an IUD placed after the honeymoon. So I was like, I don't know if that's related at all. It usually doesn't cause pain during sex, but why don't you have it taken out and see? She had it taken out. All her pain was gone. Third session, totally back to normal. And the third session, we really processed what it was like for her to fear that perhaps her dad had been sexually inappropriate towards her, which her dad had not,
The impact there, which you're just naming so clearly, like how vital it is for us as therapists to do our own work because of this potential impact in so many ways that we can have on our clients.
And I would add, it's ongoing work. It's I think if you're not a therapist and you're not doing this type of work, you may not fully understand what I'm talking about. You're like, wait, why are you in therapy now for 11 years? How does that make sense? Like after this session with you here, right. I'm going to go do some therapy. And it's because patients stir up new parts of your story in new ways. So it's like, I think it's very normal to enter into an enactment with a client. And I love this idea of enactment. It's the idea that the patient, you will start to behave differently towards a specific client due to that client's story, right? And you'll get pulled into this drama of sorts with a client. So you start behaving differently. And it's like, don't feel bad that you get pulled into the enactment, but process the enactment in your own therapy so that you don't have to continue, so that you can put words to the dynamic that's going on between you and the client for yourself. And then you can think about how to use that therapeutically as well.
Yeah. Yeah. And I'm thinking about how there's things that stir up, client material that stirs up something in me that maybe 10 years ago it wouldn't have. Like I'm in a different place in my life too. And so, that's why it's ongoing. It's like we always need to be curious about this and looking at it. I so appreciate how you're naming this.
Yeah, I think for you, I imagine having kids that are young,
right?
If the patient's talking about something around kids that age, it's like it really hits you in a new way, right?
100%.
Yeah.
Yeah.
Or I'm convinced that at every age of our kids, our own story comes back in new ways of what that was like to be a kid. And unless we're actively in process of that and finding the disavowed emotions and processing the moments of slight dissociation, we can kind of recycle the way that it was for us to our kids.
Yeah. This is like really rich territory. This is cool. But I also know there were other pieces you wanted to talk about, so I don't want to bypass or,
Let's go. Yeah.
But you were talking about dreams at one point.
Okay.
Can we shift gears into that? I'm so curious what.
Yeah, I think this is an area where it's like the psychodynamic tradition on dreams is rich. If you read Freud's interpretation of dreams, he's really pulling from all of history of that, all that he could find on dreams. He's pulling from the philosophers and art and literature. And he's kind of like looking at dreams as if there's something that they're there to teach us of value, right? Now, he thought that they were, maybe the interpretations, the way that he saw them, maybe he was blinded by his own bias, right? Because we have to remember, Freud was never analyzed himself. He was the one that analyzed other people. But I think that the rich tradition of dreams and looking at dreams goes back even further. So Aristotle talked about it, Plato, Hippocrates. There was a cult in the Greek time where they would hear people's dreams as part of like what would happen in the temple. That I think it was the Ayupusans. I'm probably pronounced that wrong. So biblically, like dreams were used to predict the future or to foretell, Israel's coming out of bondage, coming out of slavery, and it gave the whole nation hope that they weren't going to be stuck in bondage forever. So it had intense meaning. So my point in all this is like there's a rich tradition of dream work, and I think that there was an article that I read that talked about how dreams change as you progress through the trauma work. And this is something I've seen to be true. And I think this is one of the most valuable aspects of it. So probably the other valuable aspect is to getting to material that you can't get to on a conscious level, like it's hidden material. Okay. So how do you record a dream? Let's start there. I like to record a dream word for word. So I actually write down the dreams. And my long-term therapist did this. She would listen pretty much without writing anything. But once I said a dream, she would pull out her pencil and paper and start writing it down. And so I like to write it down at word for word. And I like to then look for the emotion that flashes on the face as well. So I'll put that in brackets. And then what emotion did they feel right after the dream? I usually write that down. And then if there's specific symbols in the dream, I might have them say, like, as you think about this, what comes to your mind? As the red wheelbarrow. Oh, the red wheelbarrow always represented as a kid. I used to cart around my dolls in the red wheelbarrow. So I'll write that down. So I'm not interpreting the dream. I'm having them interpret it themselves from their use of their own associations. Okay, so how do dreams change? So I had this one male client who was viciously attacked. He had a big job, highly successful career, and he was viciously attacked in the newspapers and in the court systems for this 1-year period. And this was the year that he developed nightmares. He kind of like crumbled psychologically. He developed panic attacks. And so in his dreams, he was in the court being yelled at by the judge, being yelled at by the prosecutor. He was being like harassed in the newspapers. And so in different ways, right? So interesting side tidbit, malingering PTSD. So sometimes people lie about their trauma, right? For secondary gain, for primary gain. They tell their trauma story in the dream is always the same. And that's never how it happens actually in real life.
Interesting.
So the dreams always change slightly. And it's never the exact replica of your trauma over and over again. That's just not how dreams happen.
Right.
So for him, it was like different scenarios in the court, in the newspapers. And then as the year unfolded and he processed this, and his dreams would change. So by the end of our work, he was in the court and they were throwing him a birthday party in the court.
That's a shift.
Yeah. And he would return to the traumatic event in his dream, but it wouldn't be a traumatic situation.
Yeah.
So over time, the dreams change in this capacity, right? Another example would be a female client who would have dreams of a tidal wave hitting her. And then she would either be in a house or in a situation, and she would be seeing this tidal wave come up over her and crash over her, and she would wake up in this like suffocating feeling. And over the course of our work, there was one point where there was a male who was tall, who would create a dome around her to protect her from the tidal wave. Of course, I'm like this tall, big guy. So it kind of represented me as like in the therapy work, in the midst of the trauma and the overwhelm, there was a feeling of like someone protecting her.
Yeah.
Right. And so the dream, you as the therapist can also enter into the dream. Dr. Tar, my mentor, he would enter in as a black bear. His last name Tar, black, and a bear. He was a, I don't know, for some reason, like different patients saw him as this kind of bear-like figure in their dreams. So you may be inserted into the dream in a positive way. Clients don't always see that as you as there. And sometimes they can associate to it. I would never lead someone to it. And sometimes it's almost like too much for them to realize that. But yeah, it's a fascinating thing to be entered into their dreams in a positive way. I think it's a good sign that the work is progressing well.
Yeah. Yeah. I'm just thinking about, how complex trauma shapes a person, shapes their experience as chronic, over time. And what I'm hearing in that, or how it's landing for me, is like, and that there can be like this positive spiral up also. There can be a chronic, in the positive direction through the course of, maybe years even of working with a client, that there can be that positive sort of chronic impact. Complex. What would the word be? I don't know. Complex. I'm not sure.
It would be a stable, caring person, a corrective emotional experience, this kind of internalized other, like an internalized, in object relations theory, we might consider it like an internalized loving person, right? And I think the other thing there's a couple things I really want to talk about as well, like transference, countertransference, projective identification, splitting. I think these would be valuable topics as well. I don't know how long we're going, so this might be like.
I'm looking at the clock going, I'll just be here as long as you want to talk.
Okay. Because I think the things that I feel like the modern clinician is not well prepared for is your feelings towards the client that may be, either overly positive or overly negative. And I think we can feel shame towards both of those.
Yeah.
Right?
Yeah.
We can be activated in ways that are incredibly potent, with both loving and hating feelings. And the patient can feel very strong feelings towards us as well. And I think that's inevitable in the work that we do, that the patient will feel anger towards us, possibly first. We could be the first place that they could feel safe enough to feel anger towards. And so when we're dealing with disavowed emotion, they could feel negative towards us, and then they could also feel shame for feeling negative towards us. They could feel like, I shouldn't feel frustrated at Dr. Puder, or I shouldn't feel like, one person told me, I don't think she would care that I shared this, that she felt like I was a coward for not posting political things. because I try to stay away from politics in my podcast completely. Like I just completely stay away from it. And as I try to stay away in any session, I think like that's not therapy to share my viewpoints, you know? And so, you know, but what was, instead of taking this as an insult, I actually really was excited that she was able to share. And, and that's kind of a new experience for a person who is used to an authority figure maybe having a hard time with anything negative that you share towards them. Any frustration, any anger is shamed immediately and then disavowed. So you can't feel that. And I also have to say, it's not always a pleasant experience.
Sure.
When a person gets upset at you. And it's sometimes the someone who is more on like a borderline level of functioning, or like more of using primitive defenses, they have a lot of splitting, so they go back and forth between idealization of you and devaluation of you.
Right.
And if you're a clinician not prepared for that, that could be one of the most painful experiences of your career, is to be devalued. And I would say devalued often in a subtle way, and in subtle jabs and subtle forms where it like makes less of your work as a therapist too. And you can, if you're more of a naturally self-critical person, as a lot of therapists are, you could kind of take that on and ruminate on that for, you know, and so the devaluation can be very difficult. But we have to consider that that's part of the disavowed emotion that they couldn't feel maybe towards their attachment figures early on. That we are the safest place for them to feel that. And so part of the work, I think, of talking about the interpersonal, what's going on between us, is to talk about where we may have a harder time speaking these things. So, you know, when you first start talking to patients about sharing what is the feeling between us, they may feel like what you're really asking for is to be narcissistically stroked. Like, oh, you're great, Dr. Puder, you're so wonderful. And I'm like, well, hold on. Like, actually I'm not bringing this up for myself. I'm actually bringing it up because I think the work that's really potent work, the work that increases reflective function actually, is to work in some of that, like what's going on between us. And the negative parts are as important to explore as the positive. And so, yeah, I think that we as clinicians need to talk about this more to clinicians and normalize it, and then normalize as well our countertransference, our feelings that come up. And a lot of the times our feelings that come up can give us information.
Yeah.
Especially if they're things that we normally don't feel. So I had probably the most like uncanny moment I've had is I had a patient in an inpatient setting who was not getting better by extensive treatment in ECT. And while I was with him one day, I had a very violent sexual thought come to my mind. And I was kind of into this countertransference thing where I would like look for thoughts that are rare thoughts, right? It's not my normal sort of process. And so I asked him, like, hey, do you watch, do you ever watch porn? Like, is that something you do on a regular basis? And he looked at me with this like shame expression, like, oh, and then he told me he watched 4 to 6 hours a day. And then I found out it was violent porn. And this was the big issue with him. Like, this was like,
that was the thing.
This was the thing that like was the unsaid thing, that was the conflict between him and his wife as well, that was this that was tied as well to his personality pathology.
Yeah.
And I say pathology here because obviously like there's a very maladaptive component to this that he felt a lot of shame about.
Mm-hmm.
And so sometimes I share this story to illustrate like sometimes these rare thoughts that we get in our mind when we're with someone like give us a glimpse of the other's mind.
It is so wild to me, moments like that. I've had a few situations where I'm also realizing I'm resonating with something going on over here. This is not mine. And like I love this invitation of getting curious about it. Like that doesn't make sense for that to come up for me. Like that's not something that, I think it doesn't track. And so getting curious about, is this something that is happening for you, or what's your experience with that? I love, and I'm always curious about like what that was like. You said he kind of like had this sort of, I don't know, maybe I was just watching you and interpreting. He sort of like looked down and there was like shame or something.
A lot of shame
for him.
A lot of shame.
But I'm curious, how did that sort of unfold, and what did you do with that? When he was coming and saying, yeah, actually that's the thing. That's what I'm navigating right now.
So in some of my roles as a psychiatrist, I am not the therapist, but I'm there to work with the therapy team. So in this particular case, I talked to him about how this is important to bring forth to your lead therapist. Would you ever consider that? No, I wouldn't. And why not? And so I kind of helped him process through what the difficulties would be in sharing that. And then after I helped him through that, he was able to share it with his therapist and kind of like, and we were also able to consider like, was ECT the best treatment for this guy, or was a different type of treatment better? So we kind of shifted gears a little bit with him, and that's a difficult situation because I think a lot of therapists would hear that and be like, well, why is he like I'm going to go all bad on that guy for that? But a lot of this was tied for him in particular to his own kind of traumatic upbringing when he was, so it was kind of like a twisting of sexuality due to the trauma that he had been through. And so that unfolded with the therapist and, over time, and hopefully led to some kind of like moving towards health, moving towards, I think, the 6 hours a day it shows you the level of addiction, right?
Yeah.
So it's like, when is it an issue versus when is it like normal behavior? Like I've had therapists who go bad on someone for watching porn 20 minutes once a week, and for me, it's like, maybe that's not the biggest issue in their life. But for someone who's addicted to 6 hours a day, I mean, that is taking over their life.
Yeah. Yeah.
And so it's like, if you don't bring it forth, it's like you're missing this thing, and plus the depth of his shame.
Yeah.
And then so I'm sorry, that's a dark story. I hate to even tell stories like that. They're so like,
well, I mean, I think it illustrates some really important points that you were sharing, and sometimes, I don't know, I'm thinking sometimes it has to be like a really I don't know, that's not your typical story. And so it illustrates really well, I think, the point you were making, at least for me. I appreciated you.
Yeah. Yeah. So I think getting in touch with our countertransference, and it could be subtle. And I would advise, start to create like a countertransference journal. You interact with a friend. It's like, okay, what are the thoughts that you have with this person that are new or different that are coming up? Another good example I have is I had this client recently, and I always kind of change a couple of the little variables or keep things vague, so just to protect their identities. And but he had this betrayal at work, and it all came down. This person totally betrayed him, and it was just like 5 days ago. But interestingly, his dissociation started, a slight depersonalization started about 3 weeks before. And he didn't know why. And when he was talking about the beginning of it, I started to have images of betrayal that I had and so then I was able to kind of like, so sometimes when we have countertransference, the raw mirror neuron experience is betrayal, right? But then we put on top of that our own experiences, okay? And so we will not experience betrayal necessarily as a pure emotive experience. We will start to free associate either, in session to moments outside of the session. And so all of that in my mind is helpful to pay attention to and be curious about in our own mind, not shame our own sort of difficulty maybe of focusing, of concentrating, but why is this popping in my head right now? Does this mean anything? And it's the rare stuff. If you know your stuff, if you know your own brain, kind of like, these are the normal things that I think about during the day, that I'm preoccupied with. That's not what I'm talking about. I'm talking about more like the different stuff, right? We pay attention to those different things. Mm-hmm. And so the betrayal I have associated to incidents in my own life. So even as he was talking about the depersonalization 3 weeks prior, I was like, I feel like something started to shift then. And then I was able to pull out from him that there were subtle hints that he had intuitively of the betrayal happening before it happened.
Oh, interesting.
But he hadn't even like put to words that he had this intuitive sense. And then sorry.
It's okay.
Someone called and I jumped in. Okay, so he didn't even have this intuitive sense of the betrayal or of noticing it intuitively, but once he was able to put words to it, the dissociation in the session started to lift. Mm-hmm. So sometimes it's the meaning making, like what you were saying before, mm-hmm. like what is the adaptive reason? What is the why? What is the, if we can help them create and make sense of it, why it was there, what adaptive purpose it was serving, we can help them move out of it.
Yeah. Yeah. Oh my gosh. This is really, I'm learning so much, and I'm sure I'm going to listen back to this and
oh, you're kind. I have a hard time thinking that you're like, I think you've heard this before,
No, I'm really, and it's interesting, and maybe you experience this too, like talking to even different folks about a similar topic. Like I'm just sort of putting myself in your kind of lens, or like how I've heard you talk about things, and I'm seeing things from different angles. So I'm just really appreciating.
Well, can I ask you, like,
please?
what is the, like, as you listen to this with your background,
yeah,
what is your angle that you would see it in a different way, maybe?
Okay. So I'm sort of, okay, how do I put that into words? I feel like I don't have words. It's just when I've watched also, like I've watched some of your conversations, and there's sort of like a flavor or a resonance when I hear you talk about something, or I hear anyone talk about something. I'm sort of in my mind putting pieces together of like, what is your experience for you to see it in that way? Okay. Like, what would your experience be for you to see it in that way? Does that make sense?
Yeah.
And so I'm sort of taking on a flavor of like what this potential, and obviously I don't know you, so I'm maybe projecting some things, but there's sort of a flavor that I can connect with, and holding anyone's humanity. Like, this is how I imagine some of their experience might be for them to see something in this way or to talk about it in this way. And so as you're talking, I'm sort of putting myself into that and adopting maybe a flavor of that, of like, okay, what would that experience, or what does this feel like or look like having had that experience? I don't know how to put this into words. This is a really good question, and I don't know that I'm answering it.
It could be frustrating to feel like you don't have the words, but okay, let me ask it in a different way then.
Okay.
What are the gaps that you don't quite understand still in how I've come to where I'm at?
What are the gaps? Well, it might be that I don't know you personally. And so I don't know, and I'm not asking you to like dive into, your deep personal history, but like maybe there's things, for instance, the political piece, like it totally makes sense to me what you're saying. And what is it about that? Because there's some folks that would say, no, therapy is very political. It's really important to my clients that they know where I stand or whatever. You know what I mean? That's a different perspective. And so maybe I just don't know enough about you to know why that particularly is how you come to it, of like, I feel like I want to keep my own political views out of it and let the client really show up and share whatever is happening for them. That makes sense to me.
Yeah. Okay.
But I don't know how that's different from someone else who says, no, I think it's really important for my clients to know that they're safe with me. And in order for them to know that, they have to know my political views and that sort of thing. Does that make sense?
Okay. So one thing I would say there, maybe that's idiosyncratic about myself. And I think other therapists could vary on this point. And if they're high reflective function therapists, I would still refer to them, like I don't care.
Yeah.
So maybe my values are not to like value this above other things, right? But in my own sort of journey, as a podcaster, as someone who's out in the public, I think that I like to stay in my lane. And I think that with patients, of course, it's inevitable that they can read me, that they can watch my podcasts, but I never want them to feel like they have to behave in a certain way to get connectedness. And I think I grew up reading people and knowing how to adapt myself to get connectedness. And so and I think that's served me well as like being a therapist, knowing how to do that. But I also want people to be able to have their own journey. And so, if a patient, I was just thinking about this last night. If a patient has had their, been harmed by someone from racial things, that's their story, and so I'm going to value that. But I've also had patients who feel like they've been harmed from racial things, where it's like part of their schizophrenia and paranoia. Like I had this white patient who, during his manic episode, got a bunch of white pride tattoos, and that may be very off-putting for someone who's like this is the epitome of like awfulness, right? Like here's a guy who's like, he learned a bunch of white supremacy attitudes. But the why it was important was largely because he was manic. Like once he became not manic, and I got him on lithium and olanzapine and and this is a guy who like really had true mania, where he would stay up, not sleep all day, be in a murderous rage. And I had tried to get him off medications because I thought he was mostly personality stuff. And then he got manic and started yelling at me for like an hour straight, but it was like a weird yelling, like got homicidal. And so put him back on meds. And then eventually he married a person who is not his race. And so
interesting,
like he got the tattoos removed, and so I think like, for him, he had this journey out of what I would consider something very pathological.
Yeah.
But if I overly invested myself and got disgusted in that early on, I may have missed the bigger picture of like his personality pathology, his bipolar, and how those contributed. And so I think that it takes a lot of, it's like, is it just political? Is suffering just political? Suffering has been going on throughout all history, and I love reading history, and we've all suffered. Humanity used to be absolutely miserable. We would have 6 children because 2 would survive. Like that's what it's like to be in a developing country still to this day, actually. And so suffering is ubiquitous, and the unique suffering of the client is what I focus on. And I think if I put my own ideology out there too much, opinions, it may they may subtly conform to it because of idealization and how common that is.
Yeah.
And my position of power.
Right. You're naming something really important for me, and I think it's been a gap. But I mean, that was the question you asked, is like, what is it that's, creating that gap? And you're absolutely naming it for myself. I haven't known quite how to articulate what you're saying. Like there was always something there for me and not totally understanding, like, why is it that I see it this way? So I'm really appreciating this invitation to look at it from this angle. I can see how it really, I imagine it really deepens your work in ways that are important. So yeah, I appreciate you sharing that.
Yeah.
And turning the tables a little bit on me and asking me.
I feel like I haven't enough already. I feel like
no, this is so great. Wow. Well, you've been so generous with your time, and I appreciate you taking your time and putting you really are bringing yourself to all your interviews, all the work that you're doing with clients and on your podcast. And I feel like there's probably 10 more questions I wanted to ask you, or more than that. And we didn't talk about the connection index, so maybe I can have you back and ask you more about that, because I think that's really, I mean, I don't know if you'd want to talk about it now, but this tracking connection.
I'll give you my 2 cents on it.
Do.
So this is kind of, this is part of my story of like, wanting to improve the lives of residents when I was an attending. And one of the ways was to look at connectedness that the residents experience towards specific attendings. And in training, inevitably, you are in a position where you have to behave in order to graduate and be a doctor, like be a physician. Like you have to hold in your own personal views. Sometimes you have to, if you feel like your attending is being unethical, you have to like quietly go along just to get through, right?
Play the game.
And so there's a huge power imbalance. And so the connection index allows residents to grade their supervisors. And the idea was not to penalize the supervisors, but to give them honest feedback. And so I created the connection index, and we looked at that with burnout. And we found that if you had a really, really connected supervisor, your burnout was lower. Your sense of a personal accomplishment was higher. Your depersonalization, which is a facet of burnout, it's like kind of more of the shutdown stuff, was lower. You were not as shut down. You were doing better. So it was really interesting to look at that. And I rolled it out in some different departments at the institution I was at. And we looked at like different sub-surgery specialties and anesthesia. And I was able to like sit down with attendings and give them feedback and kind of help them consider how to improve their abilities. I think it was really important. So I created a connection index. It's a paper it's very statistically nuanced. If anyone's interested in getting a copy of it, you could shoot me an email. I'm more than happy to just share the share the paper, share the manual I created. And it looks at things like empathy, therapeutic alliance, feedback, and psychological safety.
Okay.
And
So
all in one measure.
So when you're talking about the connection of a supervisor or someone in that position, you're talking about capacity for these different areas.
So like how empathic you experience the supervisor, your connectedness, your psychological safety is another. It's a whole domain of research that's been done. It's amazing research. Like your ability to take a risk and share something with them when you disagree with them, share feedback with them. Like, is there open communication for things that you disagree with the attending? And so all of this leads to connection, right? And so what I found was you can't be high in empathy and low in feedback. You can't, they all flow together.
Yeah.
So it really is one domain of connectedness. And there were some attendings that scored high all the time, and we even I retested a department because they were like, oh, I don't know if we can give this to the attendings because like, what if it's not accurate? So we retested that. And this is a 7-point index, and every attending scored within like half a point of they did 6 months prior.
Oh, interesting.
And so it was like they hadn't changed, right?
Okay.
And and so in the process of this, I learned like one that I had been through this residency, 5 or 6 years before. I learned that some of my bad experiences were like other people were having bad experiences with these people as well. And there was one attending, we just stopped allowing that person to supervise residents because the scores were so low. Wow. And so it gave us like a data point of like, no, like there is something going on here. So if someone scored below 4, bias, bullying, and harassment jumped up. Unless they scored below a 4, it didn't jump up. So yeah, it was fascinating.
Wow.
And I, I moved to Florida, so a couple of the projects kind of got put on infinite hold because my life goals changed a little bit. It was like a real research project, and it was a lot, but it wasn't. My life is not producing, research. I have a lot of respect for people that do that.
But I'm here in that I'm hearing so many different applications. Like as you were talking about, I'm like, this is like parents could use.
Oh yeah.
So,
yeah.
Anyone in that, in sort of an authority kind of role. Because if our kids feel like we're high in empathy and all these other things that you named, like the value there. So
absolutely. Yeah. There, our connectedness with our clients is paramount,
Yeah.
But then what we don't also think about is like pursuing supervisors who we feel connected with. And I would actually say one of the errors of the next generation of therapists is they want to go off on their own too quickly.
Yeah.
Without good supervision and without ongoing connectedness with people who have decades of experience. And so for me, having the podcast gives me an avenue of having connectedness with great mentors, Yeah. And there's been times where I've sent Nancy McWilliams a message, and she's sent a message back that's been incredibly life-changing.
Yeah.
On like some supervision or, my relationship with Dr. Tar for a decade, we spent 5 hours a week together, teaching residents, going over stuff. So yeah, for the next generation, I would say it's a good investment to find that person that you feel very connected with, who's had decades of experience and practices in a way that you look up to. And to financially invest in that is paramount. And I would say it's totally undervalued. And I was just talking to a person yesterday, we had lunch, and he was saying that's the biggest issue he saw. And I was like, yeah, I think I see that too.
Yeah.
Yeah. So yeah, oh man, there's so many things that we could talk about, Emily. I
Well,
feel like I feel like you have to share something like that was like this stirred up in you, just something small, right?
yeah, what did this stir up in me? I mean, I think it just reminds me, to get more curious
Okay.
and, and, um, and just, I feel like just when I start learning something and I think I'm getting a handle on this, like that's when I get complacent. That's when I start missing things because I'm not as curious and kind of like with that beginner's mindset. And I mean, I mentioned multiple times throughout our conversation the whole parenthood piece. My
Mm.
oldest is turning 18 in a month. My youngest is 6. So
Wow.
I've
Okay.
got a gap that, I've got a lot to learn. And I think how I'm sort of translating some of what you're saying is like remembering in parenthood. I feel like in many ways it's easier for me to be curious with clients as a parent. Sometimes I think I know, and there's times I don't know. So that's, to be personal. That's kind of
Yeah.
what's landing for me in this moment.
Yeah. Absolutely. Like you have your it's when you have your own kids, that it stirs up your attachment stuff so much more,
Yes.
right? So it's like so much harder to overcome uh that piece. Yeah.
Yeah, and what you named earlier is like as my children are moving into new seasons of life, like just like you said, it's stirring up pieces of my experience at that age. And I'm like, no, 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 they're their own person. They're
Right.
living their own path and they're figuring it out. And I don't need to project my stuff onto them and like giving them that space. So,
Yeah. No, I have kids. I have kids too. I have 2 kids.
hmm
Uh, which none of I never post pictures online of my kids, so people who follow me, they haven't seen like them grow up at all.
hmm
Someday I might post them, but I'd want to kind of wait for their adult
hmm
permission, or I don't know.
Yeah, consent.
Um, it's like it's such a beautiful journey to be a father. I love being a father. It's probably one of the joys of what of my week. And but at the same time, it stirs up a lot of things when I'm giving my kids sometimes things that I didn't have when I was a kid. And it's a different experience for them to
hmm
have the things that I didn't have, and they experience it differently.
hmm
So
hmm
there's some interesting pieces there. Yeah.
Yeah. Yeah. Well, I appreciate you. I appreciate the work you're doing in the world and appreciate you taking the time and sharing so openly what you're learning. You're in the trenches very much and just,
Yeah.
yeah, really grateful for the work you're doing.
Yeah. That's good. I had one person who wrote to me that they didn't like that I said in the trenches. But then when I was like, no, like I'm in the trenches with my patient, we're fighting together,
Yeah.
because the person got offended because they were thinking like
Oh,
I was fighting this adversary while I was in the trench alone fighting. And I
oh
was like,
no.
no, like we're there together.
Yeah.
And I think the point is like we're together suffering in a sense. Like, I mean, I think there are people who get so successful on podcasts or whatever that's what they end up doing, right? It's like most of my week is seeing patients, and
hmm
I don't know if even if I was more successful, I probably would continue to do that,
Yeah.
like so.
Well, that's it. To me, when I hear you and I listen to your work, and
Yeah,
it's like that's the spark. That's where the fire comes from.
yeah.
That's how I'm holding it. And I
Oh,
and I
okay.
totally had that image of like you're in the trenches with patients. It's not like you're out there fighting, It's really that relationship is clear, so clear to me. So,
Yeah,
yeah.
yeah, yeah.
Well,
This is great. Yeah, it's very nice to meet you. I think you should post the video, because I
okay,
think
you're
like your
You're going to be the
attunement
first
level.
one actually that I've videoed. All of them,
Okay,
we've just recorded sound. And I was like, he seems comfortable. We're going to record
let's
video
do
as
it.
well. And if
Yeah.
you're saying that's cool, then that'd be awesome.
Yeah, I'll post, if you don't want to post the video, or if you can share the video with me, I'll post it to my my ex account, it's just David Puder. P as in Paul, U as in under, D as in dragon, E as in elephant, R as in raptor, for those of you who don't know how to spell Puder. I use more masculine words like dragon and raptor. I used to use things like daffodil or like, Daisy or, Now
you've got the raptors and the dragons.
I try to use more masculine words. So yeah, no, but I would love to post this to my ex. I think there's like that. I think my people would love to hear it. So
awesome.
Yeah.
Well, thank you again for taking the time. I'm like I said, there's so many things we could keep talking about. I have so many more questions, so maybe we'll get the chance to have you back. But just appreciate you.
Okay. All right. We'll leave it there for today then. Thank you.
All right. Sounds good. Take care. Thanks so much for joining us for today's episode. To find more information about our guest, check the show notes or visit us at complextraumatrainingcenter.com/transforming trauma. You can also connect with us in other ways. We are on Instagram, Facebook, and YouTube. As a mental health professional, your commitment to healing and growth inspires us. We at the Complex Trauma Training Center are committed to supporting you in your well-being and success. That's why we are honored to invite you to our Space Program 2026, an interdevelopment program of support and self-discovery for therapists on the personal, interpersonal, and transpersonal levels. Running over 6 online sessions in 2026, this interactive experiential learning program is designed to support self-care and self-discovery for therapists exploring internally, relationally, and transpersonally. CTTC faculty will welcome you into a professional community of therapists that are seeking to create greater effectiveness and resilience in our professional lives. As CTTC faculty Brad Kammer says, the intent is that this program will help us not only become more effective therapists, but also love our work more. Please visit complextraumatrainingcenter.com and secure your spot in the 2026 Space Program. Thanks to Rig for producing and editing, to Tori Essex for our album art, and to Brad Kammer for the creation of this podcast. We look forward to building community and connection with you and changing the world by transforming trauma.